Hello, this is Dr. Alley, and before we get too far along in our journey of immunology, it makes a lot of sense to start talking about the cells that are involved in the immune responses. A common question that tends to pop up on the step 1 is, what is the site of hematopoiesis? Now, I'm hoping that most of you have stopped and said, well, what's the site of hematopoiesis when? And that is based on the fact that hematopoiesis is going to change location depending on what stage of development you are in. During embryogenesis and early fetal development, when the organs have not yet completely formed, there is an external source of hematopoiesis within the yolk sac. As you transition through fetal development and go through organogenesis, hematopoiesis is going to stop in the yolk sac and it will be picked up in the liver and the spleen. And the liver and the spleen will continue to be the site of hematopoiesis until the fetus has started to develop the skeletal system. And once a child is born and all the way through adulthood, the bones are going to remain the primary site. Now, a couple of distinctions that I want to make. When you're very young, the primary site of hematopoiesis tends to be within the distal long bones. But as you age, that is going to shift. Remember that a lot of your bone marrow is going to be replaced with fat. And as you age, hematopoiesis tends to take place primarily within the axial skeletons, in particular within the vertebral bodies. All the cells that are derived during hematopoiesis originated from a very small population of cells referred to as multipotent stem cells. If you can imagine, a stem cell will undergo a division, and from that division you will have 2 new daughter cells. This is a great opportunity to explain some of the characteristics of these cells. First and foremost, one of those cells is going to be used to regenerate the population of stem cells. This is a term that we refer to as self-renewal. The other daughter cell now has the potential or potency to give rise to either a common lymphoid progenitor cell line, which can go on to become a B or T lymphocyte, or even a natural killer cell. Or that cell could go on to become a common myeloid progenitor cell, in which the remaining blood cells are going to be produced. One distinguishing feature of the stem cells that I need to ask you to really commit to memory is that on the surface of the stem cells, they also express a unique surface marker called CD34. This particular slide is a very nice overview of hematopoiesis. Because it's so busy, we are going to have to take a little bit of time walking through it. But let's go ahead and we're going to start with our multipotent stem cell. Remember that our multipotent stem cell is defined by the surface marker CD34. And this particular stem cell, upon division, is going to have to make a decision as to whether it wants to become a lymphoid stem cell or a myeloid stem cell. So you should be asking yourself at this point, well, what is it exactly that is going to drive differentiation down one pathway or the other? Normally, you have very well-defined percentages of these cells that are produced, but during times of pathology, especially when you have an infectious disease, you are going to shift priority to one or the other of these pathways. So, as an example, when you have a viral infection, you're probably going to want to spend more time producing the lymphoid stem cells versus the myeloid stem cells. And when you have a bacterial infection or a parasitic infection or even a fungal infection, you probably want to produce more cells that are derived from the myeloid stem cell line. So in the presence of these different infections, the body is going to respond by producing, different cytokines. So If I want to go down the lymphoid stem cell pathway, the body will produce lots and lots of IL-7, and that will cause your first differentiation step. From my lymphoid stem cell, though, I can get 3 different lymphocytes. Typically, what you anticipate with your lymphocytes are your B lymphocytes and your T lymphocytes, but let's not forget that from this stem cell, you will also be able to produce your natural killer cells, which are a type of lymphocyte, but this particular lymphocyte contributes to the innate immune response when you have things like viral infections or transformed cells. Our B cells and our T cells are going to take a little bit of a different pathway. Our B cells are really, really laid back. They're happy being in the bone marrow. They're going to stay in the bone marrow, and they are going to go through their development, which we're going to go through in the next chapter. Our B progenitor cells will eventually differentiate into mature naive B cells, and those mature naive B cells will exit the bone marrow, and they will spend the rest of their happy little lives searching out their antigen. Once they have encountered their antigen, the B cell is then going to differentiate into its terminal form of the plasma cell. T cells, though, are a handful. They're very, very high maintenance. They're fairly ungrateful being in the bone marrow. And they decide that, hey, I'm too good for this place. So they tend to exit the bone marrow, travel to the thymus. They get to assume a new identity. They get to now call themselves thymocytes. And it is within the thymus that they will undergo their development and terminally differentiate into one of 2 larger groups of T cells. They will either become CD4 positive T cells, which will supply our helper T lymphocyte population, or they will become CD8 positive T cells, which will serve as the precursor for the activated form cytotoxic T lymphocytes. So again, all of these cells are going to be derived from the presence of IL-7. If I want to go down the other pathway, I am going to need a different set of cytokines, and actually I'm going to engage a growth factor here. So I will have, in the presence of infections like bacterial infections, parasitic infections, fungal infections, I'm going to be producing a lot more of GM-CSF, which is my granulocyte monocyte colony stimulating factor, and lots of the interleukin or cytokine IL-3. This will cause differentiation of that multipotent stem cell to a myeloid stem cell. And boy, does the myeloid stem cell have a lot of different careers that it can choose from. One of the choices that a myeloid stem cell can make is to differentiate into a granulocyte monocyte progenitor. I'm hoping you figure from this particular cell, I'm going to get lots of different granulocytes and monocytes. Well, the principal granulocyte that is going to be produced is going to be our neutrophils. I will also produce my monocytes. Remember, those monocytes are as we like to playfully refer to them as, they are our baby macrophage or our juvenile macrophage. And once that monocyte exits the bloodstream and gets into the tissue, it will become a macrophage. And also from this, it is believed that we derive our phagocytes referred to as dendritic cells. Please be careful here because a lot of the literature is now showing that dendritic cells are actually derived from both a lymphoid stem cell lineage as well as a myeloid stem cell lineage. The good part of that is because there is that discrepancy on the source, you're not going to see a lot of questions on the step 1. Or I think it's probably safer to say you should not see any questions. Now, that myeloid stem cell, we can go back to it. If I have something like a parasitic infection Or if I'm having a type 1 hypersensitivity, I'm going to see the production of a lot of IL-5. And IL-5 is responsible for increasing the number of eosinophils that are being produced in the bone marrow and also being released into the bloodstream. So it's extremely important that whenever you hear the cytokine IL-5, that you are immediately thinking about an increase in the number of eosinophils. Couple of others let's add to this. We can also derive basophil progenitor cells from the myeloid stem cell. There is a little bit of debate also in the literature about what is the exact source of a mast cell. A lot of textbooks will say that the mast cell is derived from the basophil progenitor. Other textbooks are going to say that the mast cell is derived directly from the myeloid stem cell. And again, because of the debate, I would not concern yourselves with questions about the origin of these particular granulocytes. I would remember, though, that from a basophil progenitor, I am going to get my basophils. And finally, the two other cell types that will come off the myeloid stem cell are our megakaryocytes. So in the presence of thrombopoietin, my myeloid stem cell will differentiate into a megakaryocyte. Now, megakaryocytes do not leave the bone marrow. They stay within the bone marrow, and if they receive a signal in the form of the cytokine IL-11, they will increase their production of platelets. Please recall that the other name for platelets is thrombocytes, so again, don't be surprised if you see one or the other on the step 1. And then finally, the other cell line that can be derived from a myeloid stem cell are our erythroid progenitors. And these are going to be produced in response to increased levels of erythropoietin, which is produced by the kidney in response to low oxygen levels. So EPO will give me my mature red blood cells or my erythrocytes. This is a very good figure for you to be able to walk through and understand the variety of different lineages that we have and which cells come off which progenitor cell. Just as a quick review, please remind yourself that after the completion of differentiation within the bone marrow, all of these cells are going to have unique, specialized function once they exit into the periphery. The myeloid lineage cells, with the exception of our red blood cells and our megakaryocytes, are all going to contribute to the performance of the innate immune response. And remember, those are then going to be non-specific responses that we are going to see immediately upon activation of the immune response. Our cells derived from the lymphoid progenitor cells unfortunately don't follow the same rules. Remember, we will get our B and our T lymphocytes. Those are going to be our two cells that are going to participate in the adaptive immune response, having very high levels of specificity. And we are also going to produce from the progenitor cell our natural killer cells. Our natural killer cells are, yes, lymphocytes, and you will get questions about that, but they are going to be part of the innate immune response, and Dr. Moscatello is going to go into details about how the natural killer cells are capable of recognizing intracellularly infected cells as well as tumor cells and participate in their destruction. At this point, I'd like to encourage you to start asking the question, how is it that I'm going to be tested on this various material? So really, how important is hematopoiesis? How important is it to know all these different white blood cells? Well, one of the things that I really need to impress upon you is that sometimes it's really just knowing normal values that it's going to lend itself to determining certain pathological states. Now recall, when you get a white blood cell count and differential, you are typically going to get back a series of percentages. You will get information not only about the proportions of the different leukocytes in the bloodstream, but also changes in morphology. So typically a CBC differential is going to include counts of your erythrocytes. You're going to get platelet counts, but with regards to your leukocytes, you're typically going to see inclusion of your proportions of neutrophils. Falling under your neutrophils, they will also give you a count of your band cells. You will get a complete count of your lymphocytes, and those lymphocytes are going to include your B, T, as well as your NK cells. You will receive counts for your monocyte levels, eosinophil levels, and then finally basophil levels. Notice that that is not all of the leukocytes, but again, you can derive a lot of information just from this subset. I really dislike asking you to memorize a lot of numbers or percentages, but this is one table that I will say is going to save you a lot of time if you understand the relative proportions of these different white blood cells to one another. Now, they are listed in typically how they appear as far as percentage-wise. Neutrophils are always the most abundant white blood cells. Depending on what reference you're looking at, it is going to have about 50 to 70% of the white blood cells. As a subcategory of the neutrophils, you will also get a number of your band cells. Band cells, remember, appear when you have the premature release of immature neutrophils from the bone marrow in response to an acute infection, especially when you're dealing with a bacterial infection. Next on the list after neutrophils are going to be our lymphocytes. Lymphocytes typically are going to comprise about 20 to 40% of your white blood cell count. And you would see a shift in your number of lymphocytes when you have things like viral infections. You would anticipate a much higher lymphocyte count for a viral infection versus a bacterial infection. Right in the middle of all this are our monocytes, those little baby macrophage. They typically will have an upper range of about 10% of the cells. And then we have our last two contenders here, eosinophils and basophils. The values of both of these can be extremely low. Sometimes you won't even find the eosinophils or the basophils within a blood smear. So again, if you see them, it's usually a rare occasion. If you see very high proportions of eosinophils and basophils, you need to immediately start to say, well, I most likely have a severe parasitic infection, or I'm dealing with a strong type 1 hypersensitivity. And usually what you will get is this information within the clinical vignette, and what you are going to have to do is to determine what type of infectious agent is causing the change in the cell proportions. Well, since we've covered what you're going to see on a blood smear and the information that's going to be pertinent for you, let's go ahead and expand a little bit on each of these cells just to ensure that you are very comfortable with identifying those major subsets of leukocytes on a blood smear. Now, I know you're saying to yourself, they're never going to give me histology on the step 1. But unfortunately, sometimes you will see histological images of things like neutrophils and lymphocytes and monocytes. And I highly encourage you to be able to recognize them, not only based on an image, but also based on a description of the cell. So let's go very briskly through these. We have our first cell, our most abundant cell, is our neutrophil, also called polymorphonuclear or PMN cells, which that name tells you, hey, my nucleus might look a little bit different. So whenever you look at any of these cells, the first thing you need to do is to look at the nucleus. And as you will see from the image of the nucleus here from a blood smear, it has a multi-lobed nucleus. You will find up to 5 different lobes in a neutrophil. Now, the next thing I always tell you to look at is look at the cytoplasm of these cells. Within the cytoplasm, you will note that there is the appearance of these small, pinkish, purplish, depending on the image that you're looking at, cytoplasmic granules. So I always say the neutrophil is probably the easiest white blood cell to pick out. The other thing that I want to point out is the size of the neutrophil relative to the red blood cell. It is larger. The activity of our neutrophil is that it primarily circulates in the bloodstream until it has a reason to exit the bloodstream and get into the tissue when you have an infection where its phagocytic activity is going to be mandated, or when you have an inflammatory response. This is always going to be the first white blood cell to go into these sites. Next on our list are going to be our lymphocytes. I do want to remind you that when you are looking at the proportion of lymphocytes, those are going to include your B and T lymphocytes as well as your natural killer cells. Now, if again you look at a blood smear, what are you looking for with a mature lymphocyte? What you are going to see is a very large, centrally located round nucleus. And surrounding that is a very thin halo or rim of cytoplasm. Now, these two things are very much indicative that you have a lymphocyte. So how do you clinch it that this is a lymphocyte? You look at the size relative to the surrounding red blood cells. Unlike all of the other white blood cells, your lymphocyte is almost the same size as an RBC. Now, the other question that comes up is, hey, I want you to tell me if that particular lymphocyte is a B or a T cell. And truthfully, you do not have the capability of differentiating between those on a histological examination. So instead, you have to utilize the process of flow cytometry and look for some of the unique markers that we are going to talk to you about that are found on B cells versus T cells. Now, there are several markers that you need to commit to memory. For our B lymphocytes, be aware that they express CD19, 20, and 21 on their surface, versus our T lymphocytes, which express none of those. Instead, all of our T lymphocytes are going to express CD3, and those population of T cells can then be further divided into being either CD4 positive or CD8 positive. Functionality of these cells is nothing until they reach their final destination and are activated in a secondary lymphoid tissue. In addition to the mature, naive B and T lymphocytes, you will also see some of the terminally differentiated B cells that we call our plasma cells. If you look at the image of the plasma cell, it has a distinct appearance, is extremely large relative to the red blood cells. Its nucleus is not centrally located, but rather offset or eccentric. Sometimes you will see a very old buzzword associated with the plasma cell where they will say the cell has a clock-faced nucleus. Immediately think it is a plasma cell. And then there's one other characteristic of the plasma cells that help identify it, is that you have adjacent to that nucleus a very, very intensely staining Golgi apparatus. And that is because of the high turnover of the antibodies by the plasma cells. The other lymphocyte that we can find in the bloodstream is going to be our natural killer cells. I don't think I have ever seen a question or had a student tell me that they have seen a question that demands they identify histologically what a natural killer cell looks like. But what will be important is that you know what the surface markers are that we use to identify it. You need to commit to memory here that on the surface of my natural killer cell, I am going to have both the marker CD16 as well as CD56, and Dr. Moscatello is going to define what the actual function of each of those markers are for you in a little while. The Functionality of my natural killer cells is twofold. My natural killer cells are going to either target virally infected cells or they are going to clear tumor cells. And here is our sweet monocyte. So again, go through the process when you are looking at the cells. Notice that the nucleus of the monocyte has a shape that resembles either a kidney bean or a horseshoe, or even better, a kidney shape. When you examine the cytoplasm, notice that this is an agranular cell. And if you look at the size of the monocyte relative to the red blood cells, it is significantly larger. The monocyte, once it exits the bloodstream and gets into the tissue, remember it is going to differentiate or mature into its final macrophage form. Within the tissue, the macrophage is probably the most important cell with regards to initiation of the innate immune response. The structure of the macrophage relative to the monocyte actually reflects that it has a higher level of activity. Even though it is considered an agranule cell, you will see an increase of cytoplasmic vesicles, and you will also observe that the plasma membrane or the cell surface membrane is much more extensive, reflecting its high level of activity. Interestingly, we do not get a dendritic cell count when we are looking at the cells of the blood. And that is because most of your dendritic cells are going to reside within the epithelial layer or in underlying lymphoid tissues. But very similar to the macrophage, the dendritic cells play a significant role in initiation of an innate immune response. And moreover, the dendritic cell is the primary antigen-presenting cell that is going to be able to initiate the adaptive immune response. Our eosinophils, though, are going to be recognized on a blood smear. And I actually love the eosinophil almost as much as I love the basophil because they're so easy to recognize. So if you're looking at the image, again, where do we start? Always start with the nucleus. The nucleus of an eosinophil is bilobed. When I look at this, what I think of are those amazing headphones that everybody is wearing now that they used to wear in the 1970s that made you look ridiculous, but they're back in fashion. And I think every single birthday, anniversary, holiday, I asked my husband to buy me a pair of, the Beats headphones, and apparently he doesn't love me enough to buy them for me. But every time I see an eosinophil, I'm like, hey, those are the headphones I will never own. So this bilobed nucleus. Also, if you look at them, you will notice that they are densely packed in their cytoplasm with these pink granules. And then do the final step. Look at it relative to the size of the red blood cell, much larger. Now, I'm hoping that you can remember from a few slides ago, what is the cytokine that will increase the number of eosinophils in response to something like a parasitic infection or a type 1 hypersensitivity? I knew you knew it. IL-5. So whenever you have a parasitic infection or a type 1 hypersensitivity, the level of IL-5 increases, and I will increase my number of eosinophils in the bloodstream and in the tissue. Like the dendritic cells, I do not expect you to get a lot of histological images of or questions regarding the appearance of mast cells. Again, they're not given in a differential. So what I do need you to know about mast cells, though, are where they are typically located. They tend to associate with the blood vessels, especially the blood vessels that are associated with the skin and the mucosal layer. Mast cells, like our eosinophils, participate in the elimination of extracellular parasites, which, we don't have a lot of extracellular parasitic infections going on in the U.S. Rather, these mast cells, as well as our eosinophils, are typically going to be associated with our type 1 hypersensitivities or allergic reactions. Oh, last but not least, here's another one of my favorites. We got another cell that has a bilobed nucleus, our basophil, it sort of always makes me laugh because the figures that you see of the basophil, you can clearly see that bilobed nucleus. Remember the headphones? Anybody wants to buy me those headphones, feel free to. But if you look at an actual blood smear, what you will notice is that it's really hard to see the nucleus. So matter of fact, the cytoplasmic granules are so dense in a basophil that they occlude viewing of the nucleus. So to me, this is actually the easiest cell to pick out because remember, if you're going for the nucleus first, you don't see one. And I'm going to, just for completeness, make you once again look at the size of this cell relative to the red blood cells and notice it is still larger. Now, to find a basophil in the bloodstream is a very special day, okay? It is not often that you will find a basophil on a blood smear. Now, to find 2 or 3 basophils on a blood smear is a huge red flag that you have some sort of parasitic infection going on or another pathology. So again, be able to readily identify all of your white blood cells that I have stressed to you. Please remember the proportions. Again, very quickly, neutrophils at the highest level, followed by lymphocytes, monocytes, eosinophils, and basophils, and please recall the general proportions and know that with the changes of those proportions, you can determine the various infections.